me in a pretty good position here. I'm actually going to take this. I'm going to pull. Good. I'm going to bring this leg up. Scooch the hips a little closer to me, please. A little closer. Perfect. There we go. Going to get you to take a big breath in for me. All the way out. Good. Relax. All the way out. Very good. Yeah. Very simple. And this time I'm going to torque you out a little bit more. So I'm going to pull. Good. And you're going to hold right there. Nice. Breath in. All the way out. All the way out. Get that out. And there we go. Marty, good to meet you today. Thanks for coming in.
Nice to meet you.
What can I do for you today?
Well, I've been having some issues. I had an accident a very long time ago. Happened with my feet, and
Okay.
I've since noticed that it's kind of caused some issues down there, and then also kind of like translates into other issues I've seen from other people and other doctors who have kind of said that it stems into other types of pains. But so today I want to focus on my feet, and then also I think my back, and kind of like fixing that up.
Got it. Okay, so may I ask kind of what happened with this accident-wise a while back?
Yeah, so I was playing basketball, and as I went to jump up, I landed coming down on the side of my foot.
Okay.
So
can we see that? Yeah, we can see that in frame.
Yeah.
Perfect.
So
okay.
what I think happened was, or what the doctor said originally, was one of the ligaments on the side rolled over the bone, and I noticed ever since then, because of that, I've been stepping different. Because it took a long time to heal, and I think over time that just shifted a lot of things.
How long ago was that?
That was when I was in school, so probably about 3-4 years ago now.
3 or 4 years ago, okay. And since then, it's kind of never really felt the same then for you?
No.
Okay. All right. So we had a lot of stuff going on in the ankle. Okay, we had a lot of tendons, we had a lot of ligaments, we had a lot of nerves, arteries, veins, everything. On the lateral aspect, on the outside of the ankle, which is what would have been sprained if he does an inversion sprain, or if his foot tilts inward, keep in mind all the stuff on this side would then be stretched and pulled in a not really wanted or desired way. Most common ligament sprain of the lateral ankle is the ATFL, or the anterior tibiofibular ligament. Don't know if that was it. We're going to need to do an exam, and whether or not he's still positive or painful in that region, it depends. So, do you still get ankle pain regularly, or not particularly at this point?
Not particularly. I noticed that if I were to do something or tweak a little bit, then that similar pain comes back, but it doesn't usually persist.
Okay. Now, as Marty also mentioned, he jumped up and came down on that side ankle. So that is a lot of force versus just walking and doing a little sprain. So it is possible that this previous sprain was quite traumatic in the time, right? Our whole body's a chain. If we do have an issue lower down, we're going to start to get symptoms that present higher up unless that original issue is corrected. What have you done to try to self-manage this so far? I know you mentioned you saw with the chiropractor, not really frequently, but what have you done, or what did you do for that ankle?
Yeah, so I try to stay aware of kind of how I'm stepping and in trying to keep my feet balanced in a way to not give this ankle, I guess, a handicap of any type, and really just try and use it as much as I can.
The way that you're supposed to.
Absolutely.
Okay, good. That's smart. That's smart. You don't want to compensate going forward for the rest of your life, right?
Absolutely.
Did you see somebody for it aside from your MD, or?
No, just another chiropractor.
Fair. Okay.
But yeah.
But since then, now you're mentioning you're getting some either leg or upper back, back discomfort. Can you talk about that a little bit? Or?
Yeah, so I realized, I believe it was halfway through last year.
Okay.
I started getting knee pain.
Okay.
And that's when I forget how that came on. I do remember. So I'm a musician, and as I was setting up to play a show, I play the kick drum, and as I stepped off kicking, I realized that my knee tweaked.
Okay.
So I kind of felt it went, and then since then, it's gotten better and healed up. But I went to see my chiropractor about it, and she was saying that this could have been caused from the ankle because I was, again, adjusting for it, which then caused hip imbalances. So, yeah.
That's entirely possible. Okay, it's also possible that for whatever reason you just overused it on that one show. Okay,
For sure.
Sometimes we can equate new, more present injury to previous trauma and compensation that way. Other times, you just had a separate injury. It's not necessarily because of the ankle. That being said, the most common reason for knee pain, at least that I see in this clinic, is due to either ankle range of motion or hip range of motion issues. So because of your previous medical history with the ankle, totally possible that you were predisposed, that's the word, to developing that kind of knee discomfort. Regardless, we'll take a look at that. Anything in the back then, because I know you mentioned that it started to feel up further too.
Yeah, just general soreness in terms of like just some discomfort over time. So if I work for a 12-hour day, then I notice it getting more sore than I would originally.
Okay, all right. Well, if that's all, unless there's anything else that you feel like you should mention that I haven't perhaps asked about.
No, I think that's pretty much.
Okay, good. Well, then we're going to get into the physical exam, okay, and we'll treat you today. Any questions about that?
Nope.
No? Awesome. Let's get into it. All right, so Marty, first things first, I'm going to get you to bend down, touch your toes for me. Does that provoke any discomfort in the low back or upper back or the knee?
Mid back, and then I feel it in my hamstrings.
So mid back and hamstrings. Okay, stand up for me. And I want you to go back the other way, okay? Extend for me. Any discomfort in the low back or the legs with that?
A little bit in the lower back, but again, mid back.
Primarily the mid back, eh? Okay, you can have a seat for me now. Go. Okay, good. I want you to give yourself a tight hug. You probably earned it. Good. And I want you to rotate as far as you can that way. We can get to about, I'd say 50 degrees, just past 45. Now let's get you to rotate the other way. Okay, here we're able to get to about 40 degrees. A little bit of an asymmetry, but it's not too great. Are you right or left-handed?
Right-handed.
Right-handed. So everything here could be more tight, or that could just be the way that he's built. Who knows? That being said, we'll treat for the asymmetry there in the T-spine, no problem. Next up, we will get you on your back. All right, so Marty was saying that it was his right leg where he kind of had all of these issues, starting down with the ankle. So right now we're getting some knee discomfort most recently. How long ago did that happen again, Marty?
About half a year.
Half a year, so that was a while ago. Are you still feeling that discomfort, or has it improved since?
It's improved.
It's improved since. That's good. Okay, so we're still going to do a knee screening just to see if there is any kind of issue there. So to start with that, I'm going to just take this. I want you to keep the knee straight for me. I'm going to push inward like that. Any discomfort with that movement? No? Good. Come the other way. I'm going to push, relax that leg for me. Relax. Outward like that. Any discomfort there?
No.
No? Good. Bring this up. Place the thumb and down like so. A little bit of a click, but is that okay?
Mm-hmm.
That's fine. He said painfully.
Mm-hmm.
Yep.
Yes.
Good. And now we'll go the other way too. That's fine as well?
Yeah.
Okay, good. Any discomfort in the low back with this, or the knee?
Not the low back or the knee, but I do feel.
You're feeling a stretch in through the side aspect of this quad region, right?
Mm-hmm.
All right. So he's pointing to what's referred to as the vastus medialis obliquus, which is the inside aspect of our quad. Our quadriceps is four muscles, hence the term quad, right? And in rotating the hip inward or the knee outward, depending on which angle you're taking here, you are stretching that out. So if he's getting tender in that region on one side, possible that he's quite tight in there. So when I actually take my thumb and press into that muscle, how does that feel? Comfy or not particularly?
Not particularly.
Let's compare it to the other side, okay? Now this side would be asymptomatic, so it's good for him to check this side compared to the symptomatic side. Let's bring this up, and again, hip internal rotation. Do you feel that stretch on the inside?
I feel the stress, but it's not as much.
It's not as bad, eh? Okay, let's go ahead and let's palpate through. Not as bad?
Yeah, not as bad.
Perfect, okay. Okay, so it looks like we might have some quadriceps tightness on this side. It's not that bad. What I am going to do is I'm actually going to get you to take this knee. I want you to pull this knee into your chest for me, okay? Yeah, with your hands. Pull, 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 pull. As hard as you can. Further, 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 further. Yeah, okay. So what we're doing here is something called Thomas test 2. The quadriceps comes up from the groin region all the way down into the tibial tuberosity down here, okay? It fuses with patellar fibers. So in pulling this up, a hypertonic or tight quad muscle will also pull up the contralateral, the other-sided tibia here, okay? So he's testing positive for that. We did get elevation of this leg, so that's something we're going to be treating today. You can relax that there. As Marty mentioned, this all kind of began several years ago when he came down hard on this ankle and it inverted, meaning that the foot tilted inward undesirably, obviously, as his body weight came crashing down on top of that. So with that, like I mentioned before, the ATFL, or the anterior tibiofibular ligament, is the most commonly sprained ligament on an inversion ankle sprain, and that will be located kind of in this region here. Any discomfort as I do that, or are we pretty much healed on up?
Pretty much healed up.
Pretty much healed up. Okay, well, let's screen the other ones. Is that okay there?
Yep.
Okay, good. Might as well check the deltoid ligament, or the one on the inside. That's all okay?
Yep.
Good, okay. One thing I am noticing, just observationally looking at Marty here, is that he has quite high arches there. So I can place my hand, we can fit a good 2 fingers, and I got some quite large fingers in that hole there, and it's the same on this side too. So if you do have a higher arch, you are at a greater predisposition, once again, to getting a sprain, simply because the ankle mortise joint is slightly higher up. So that's one fun fact to notice. Let's do a range of motion check. So what I'm going to do here is I'm going to get you to try to lift this foot up towards yourself as high as you can. Good. Keep going, good. Now do the same on this side. Good. So we actually go a little bit further. It's kind of hard to visualize from this angle, but on this ankle versus this ankle. So you can relax the two there. Relax. I can do this passively. There we can get to. Boom. And then here. As well, on this side, we have less resistance on, what's this referred to, dorsiflexion, or moving the foot upwards. That does imply that we have some kind of residual lockup or some issue going on within the ankle mortise joint itself, which we can absolutely clear up and address today. So what we're going to do now is we're going to try to adjust in through the ankle mortise joint of Marty here, and also potentially the navicular too, just because of how high this arch is. So the way that we do that is, Marty, I'm actually going to get you to hold on to the table lightly for me. So it's actually quite alarming how I was taught this adjustment. One of my instructors told me you just take a grip and then you just quite literally, I quote, give her. Pull as hard as you can. But that's not exactly conducive if we're trying to be gentle with these things. So yeah, an ankle adjustment is a little bit forceful, but you do need to be controlled about it, okay? So not that any of you guys need to know that, because none of you are doing this. This is regulated, but still. All right, so you got the table there. Oh, we had actually a little crack right there. I'll shut up now and let the mic do its job. Okay, relax. And there we go. Okay, good stuff. So Marty was saying he's feeling discomfort kind of throughout the leg and also up into the lower and upper back too. So let's go ahead and have a palpate through. Actually, that right there feels quite tight to me. I don't know how that feels to you, Marty, but...
Oh, yeah.
Yeah? Okay. So definitely an asymmetry in feeling here. I wish you guys could feel, but obviously you cannot. I'm only going to adjust in kind of through your upper back, this region here, okay? So there's no way to know how much force is actually needed in order to get somebody to adjust or release on the first time. That's why practitioners kind of need to learn their individual patients. But for example, I've had 300-pound guys on this table who I could quite literally sneeze on and they would absolutely release. And I've also had 100-pound girls that I've had to all but literally body slam in order to get anything out of them. So with you, what I'm going to do is that I'm going to start off by going lighter. And if we need more, I'll add more. Okay? Understand?
Cool.
All right, so I want you to start by taking a breath in for me, all the way out. Okay. In, all the way out. There's one in, all the way out. So, harder than I would have thought, but we did get some release up in the higher aspects. that being said, it's time to do the low back. You're already in a pretty good position here. I'm actually going to take this. I'm going to pull. Good. I'm going to hold right there, just like that. Good. I'm going to bring this leg up. Nice. Scooch the hips a little closer to me, please. A little closer. Perfect. There we go. Then I'm going to get you to just relax as best you can in this position, okay? So, I'm going to get you to take a big breath in for me. All the way out. Good. Relax, relax, relax. All the way out. Very good.
Yeah.
Very simple. And this time I'm going to torque you out a little bit more. So I'm going to pull. Good. And you're going to hold right there. Nice. And we're going to hook your foot in the back of your knee there. What I'm going to do, just crawl up here. Good. You can kind of see them. Awesome. Breath in. All the way out. All the way out. All the way out. Get that out. Okay. Not that way. Let's try a different way. In. All the way out. And roll you towards me. Good. So as we mentioned earlier, we do have some tightness or restrictions within this vastus medialis obliquus group. We forgot some shorts today, so that's okay. We don't want to put boxes on YouTube, so we're gonna pass on the instrument-assisted soft tissue therapy because we do need to be directly at the skin for that. Next appointment, yeah, no problem. We'll be taking care of that off camera. But for today, what we can do is we can still do the muscle work necessary to try to calm this guy down. This is a sensitive region. Okay, so just so that you're aware, this might not feel comfortable, okay? If you don't like it, or if it, well, you won't like it, that goes without saying, but if it becomes too intense, let me know and I'll back off, okay? So, MRT, you guys have seen me do this before by taking an elbow and jamming it into somebody's upper traps or left scap. Works based off of shortening a muscle and then lengthening that muscle with a pin against the target area, okay? So we know that the quads, they are worked to be shortened straight and they are lengthened when we bring our leg in down like this. So to do MRT of the quad would involve taking a thumb, my poor thumbs, and jamming it in at a lengthened, at a shortened, and then moving into a lengthened. Does this feel okay for you? Or okay, good. You're more tolerant of it than I thought you would be. Oh, we had a knee crack there. Fun fact. I don't know if the mic picked that up, but one other fun fact about the vastus medialis obliquus, which I'm going to start calling the VMO because that's what we refer to shorthand, is that it's also the muscle that's primarily responsible for patellar tracking. So if you are getting knee pain or pain with the patella underneath it, one of the more common causes is because of inactivation or not proper firing of this muscle group. So if we do strengthen this guy, we do reactivate him enough, we can alleviate some patella-based knee pain. It's actually interesting that when I was working on it, we had that incidental patellar cavitation that could be the correction that's necessary that simply. Just because we were targeting that structure. So hey, that could have just helped. That could have been exactly what you needed for all I know. Mm-hmm. Ooh, yes I can. Heck yeah. That's a little bit more. That's probably the pressure we're actually looking for, considering this is a larger muscle group. So. Okay, we're gonna grab something here. Massage gun time. So you're gonna rotate your leg outward for me. Good. And you just keep it like that. You know, actually, just while you're laying there, one exercise that I'm going to want you to work on, and get you to just put both legs straight, is a VMO dominant straight leg raise. Okay, the way that we do that is I'm going to get you to rotate your leg outward just like so, and then I want you to lift this leg up even like 5 inches off the table, just like so. And when he does that with that external rotation, we do get primary dominance of the VMO muscle. So right now it's very fired on in that manner, okay? So if you're getting this knee pain, actually, I want you to start knocking these out, maybe let's say 15 reps, 3 sets every other day, to rebuild that mind-muscle connection so that the VMO is able to do its job unconsciously. Okay, you don't want to have to consciously move through every single movement you do, but you do need to establish those motor patterns so that the muscles can do things when you're not paying attention.
Gotcha.
Okay? Perfect. Marty, how did you find all of that?
It was good. Honestly, it was different from what I usually expect in terms of because I've seen somebody else before, and it's just that we did a bunch of things that I haven't done before. So
okay, can you elaborate on that? I'm curious to hear.
Yeah, I think it's just different methodologies, and just how you approached it was different. I thought it was great.
No, okay, no,
Yeah.
I'm happy. It's not uncommon that patients will comment kind of exactly like Marty just did. I've heard very often that people will say, "Oh, Adam, you kind of treat the way that like a good physio does," and I kind of laugh at that because, in my opinion, I just kind of treat the way that a good practitioner, period, should. Right, like physio, chiro, whatever aside, being diversified and approaching anatomical issues from different perspectives, such as the physiotherapy rehab component, or the massage therapy soft tissue component, or the chiro adjusting component. When you combine all of those things, you usually get a better outcome. So, like, I know you said a chiro before, were they just kind of more focused on adjusting, or like what's kind of?
They focus a lot on adjusting, but they do a lot of also massage therapy
Okay,
as
good,
well.
good.
But
It sounds like your chiro knows what they're doing.
For sure.
So, like, by all means, keep seeing them if they've been helping you. Once, like I said this off camera, you're not in acute pain, okay? This could very much be a you can call someone when you need them situation. And it all kind of makes sense with the history and whatnot. You're just kind of dealing with these little things as they pop up. So do you have any other questions for me before we sign off here, or?
No, I think that's pretty much it.
All right. Well, thank you so much for coming in. It's very appreciated. We can end on a high five, okay? Yeah, there you go. High five. That's how we do it there.
Good. Don't forget to like and subscribe.
Thank you, Marty.